So next, we'll turn our attention to patients whose cancer comes back after initial therapy, which we call relapsed or refractory disease. There are several options available to date for patients with relapsed refractory mantle cell lymphoma. So a lot of that depends on the length of your remission, how long has your remission lasted, and other sort of factors to take into consideration that may be present at your baseline, the time you were diagnosed, or we may find at the time of relapse. So we have late relapse with non-high-risk features, and then we have early relapse mantle cell lymphoma patients, or those with known high-risk features, such as the mutation or aberration of that protein we call P53. So some key points to remember: there are no standard of care for second-line patients. I know I sound like a broken record, but unfortunately, there is no standard of care for mantle cell lymphoma in a lot of situations. There is a preference for those Bruton tyrosine kinase inhibitors, the BTK inhibitors, such as Ibrutinib, which I mentioned before. And again, as I talked about earlier, clinical trials are very important and should always be considered a priority. So if you have a late relapse, and when I say by a late relapse, if your cancer relapses several years, typically 5 years or more after your initial treatment, what we use in it really depends on what's used in your first line treatment, what you were initially treated with. We can consider reutilization of certain agents. So bendamustine and rituximab can be repeated. R-CHOP cannot. So again, if you receive bendamustine, you can get treated again with that agent. If your remission is long enough, you cannot get a second treatment with R-CHOP. Even though the preference is to treat patients with newer drugs, again, you can, be retreated with the same treatment you had before, depending on how long it was, depending on what you were treated with in the beginning. So ignore this very busy cartoon. It's just to emphasize that Ibrutinib, which is that BTK inhibitor, targets this kinase called Bruton's tyrosine kinase. It is very important for the survival of your mantle cell lymphoma. So if you take anything from this cartoon, is that Ibrutinib and its other cousins, which we have here, acalabrutinib, zanubrutinib, they all target this one kinase, Bruton's tyrosine kinase, which means that it basically shuts off a very important survival pathway for your cancer. So that is the only thing to take away from this very busy cartoon. So if we look at Ibrutinib, when it was first approved and first reported out, showed very high overall response rate, meaning when we took a look at the picture, the number of patients who responded was much higher than what we had seen with any other treatment in that same similar patient setting. So in that relapsed refractory setting, this drug had a much, much higher overall response rate. As we see here, when we look at overall response, 68%, 67%, 68%, with modest complete responses, meaning when we took a look at the pictures, we saw no evidence of the cancer. Again, 20, 23, and 21. Important things to remember about this as we compare it to some of the other second generation BTK inhibitors, acalabrutinib and zanubrutinib that we'll talk about later. These patients were evaluated with very different pictures than what those other two drugs were evaluated in. And so these overall response rate and complete response rate may be a little bit lower because of the scans that we use compared to what those other treatments used. So why we use BTK inhibitors in a second line setting is because of this study by Dr. Rule. It basically indicated that if you use BTK inhibitors in the second line setting versus using it in third line or beyond, meaning if you use it after the initial failure of one treatment, second line, or if you use it after they fail more than one treatment, third line or beyond, you see there's a very big difference between the curves in the progression-free survival, meaning time for that cancer to come back. The top curve is if patients only had one prior line of therapy, again, treating patients in what we consider the second line. The bottom curve is if they have more than one prior line of therapy, third line and beyond. You see there's a very substantial difference in the progression-free survival, indicating that these drugs are better if they're used earlier on. Again, if we look at the bottom, this green graph, it basically talks about the duration of response. The time that the patients are responding to this drug was almost 5 years in patients who got a complete remission, which is a substantially marked improvement over what we had before. Again, sort of cementing these drugs in a second line setting. Again, this is just so more of the same. Again, further indication suggesting that these drugs are better if we use them earlier when patients are less pretreated than later, when they've had more lines of therapy. So unfortunately with Ibrutinib, there's toxicity with this drug, and these toxicities can somewhat impact the amount of time patients can stay on these treatments. This graph here, a lot of this is from patients who've had a different type of cancer that's treated with this medication, but the truth of the matter, these side effects still remains the same. So with Ibrutinib, we can see infection risk, meaning upper respiratory infections like colds, COVID, because the area we are living at right now, pneumonia, such as things like that. You can also get rash, and you can also get sort of impacts of some of your other blood numbers that are very important for us. But I think one of the bigger things that have come out from this treatment is that there is some risk to your cardiovascular system. We can see irregular heart rhythms, such as atrial fibrillation, meaning that your heart rhythm is irregular and beats very fast. You can also see other cardiac events, such as myocardial infarctions or heart attacks. You also see its incidence of increasing blood pressure over time with this medication. So again, there are cardiovascular risks, which are very important for us to keep in mind when we treat patients, and which sometimes does limit the patients we can treat with Ibrutinib. Because of this, and because of the side effects that we know with Ibrutinib, especially in regards to the heart, there were newer BTK inhibitors that were designed and developed, more selective BTK inhibitors, meaning they only really target very specific kinases, meaning they're more sort of have more fidelity to just targeting BTK, and they don't hit other kinases such as Ibrutinib. So Ibrutinib is a bit more adulterous if we want to think about a drug. It's not necessarily very sort of loyal or dependable, just hitting BTK. It will hit other kinases as well. These newer drugs, again, more fidelity, meaning they will just basically hit BTK. And the thought is it will get less side effects because of that fidelity.